Dear colleagues, I'm excited to be here today with you one more time to present one of our most recent guidelines for the ASGE, entitled Adverse Events Associated with EUS and EUS-guided Procedures. I am joined today by my good friend and colleague, Dr. Nauzer Forbes, who is a current member of the Standards of Practice Committee and the lead author on this guideline. Thank you for joining us tonight and today. Nauzer, good to see you again.
Thanks so much, Bashar. Great to be on this with you.
I have to say I've certainly enjoyed working on this guideline with you. This is a different kind of guideline because we're not really giving a lot of recommendations. Why don't you tell us from your point of view how is this guideline document different and how is it important?
Yeah, absolutely. So, thanks first of all, Bashar, for leading us on the committee and for, leading us through this this document. Obviously couldn't have been finished without you. So, it's an important point, I think, that we delve into the methodology a little bit. So some SOP committee documents follow the so-called grade framework, so the grading of recommendations, assessment, development, and evaluations framework, which is a very specific and meticulous process. So as you alluded to, these guidelines are done a little bit differently than this one. So those kind of take into account not only the available evidence, but also the quality and the certainty of the evidence, in addition to other factors such as accessibility, feasibility, intervention, cost considerations. So all these factors are then used to kind of generate a recommendation, typically by a panel. And that recommendation is on a specific intervention within a certain population. So given that there were no real questions that we were asking per se in this document, instead we simply kind of wish to summarize the available evidence on adverse events of EUS-guided procedures. So we didn't really follow a grade format for this guideline, and therefore we don't really make any recommendations per se, but instead we kind of offer summaries of the available relevant evidence and then present our best estimates of risk associated with the EUS-guided procedures.
That's very true. So I agree with you. This document did follow a previous document that the ASG has published and the Standards of Practice did earlier on about the adverse events of EUS. But we have seen a lot of changes in EUS lately, haven't we? We've seen a lot of introduction of new technologies or using EUS existing technologies to do newer things. What are some of the things that we try to address in this guideline that were not maybe addressed in our previous guideline?
Yeah, I mean, absolutely good points, right? So EUS is a very commonly performed procedure. And in fact, in recent years, there's actually good data to suggest that the volume of EUS has surpassed the ERCP even in terms of annual procedure volume. So, in addition to so-called, routine EUS, which in this document we kind of define as diagnostic EUS with or without biopsies or sampling of some kind, there are now numerous EUS-related techniques which are commonly performed. So, EUS-guided gastroenterostomy, EUS-guided biliary drainage, EUS-guided, pancreatic collection management. All of these things are very, very common these days, but were kind of not touched upon in the 2013 document. So, given that the most recent iteration of this document was now 9 years old, we felt that it was pretty important to kind of update the evidence and summarize the available evidence on adverse events associated with not just basic EUS or routine EUS, but all EUS-guided procedures.
I think one of the main things that we try to do with all of our guidelines, and we certainly did a good job here, is to try to kind of summarize everything we're trying to say in the first table or the first graph. So here in this document, we have a table 1. So in there, we listed different factors that contribute to adverse events. We also discussed the major adverse events like perforation, hemorrhage, infection, and then we kind of decided to do this based on the procedure. Do you want to tell us about some of the most common factors that are associated with adverse events in EUS and different types of EUS-guided procedures?
Yeah, so in terms of, risk factors, we're not quite at the point yet where, we can say based on the presence of certain risk factors or the absence of those risk factors that we can, alter our kind of quantitative quoted incidence of risks to the patient when we're taking informed consent. But this is just a guide to basically kind of take into account when planning whether or not to perform a procedure or instead offer alternatives. So as an example, some risk factors that have been associated with perforation in routine EUS might include trainee involvement, operator inexperience, history of difficult esophageal intubation, the presence of esophageal malignancy, C-spine osteophytes, things like that. So we try and actually elucidate those and summarize them in Table 1 so that it's kind of a handy table for endoscopists to refer to when they're taking consent. And those considerations are important when quoting risk to patients.
I agree with you. We also talked briefly on the issue of needle seeding in EUS FNA. I know I was recently in a national conference and this issue kind of came up. Still people talk about this as a potential issue. Remind us what we said about the risk of seeding in patients who undergo EUS FNA, specifically of malignancies, most commonly of the pancreas.
Yeah, it's a good question, and unfortunately, Bashar, the evidence is not quite where we'd like it to be, and we're still reliant mostly on case series and case reports when it comes to needle tract seeding. It does seem evident that kind of depends on the lesion of the location, or the location of the lesion being sampled. So, for instance, if the lesion's in the pancreatic head, it can be inconsequential in terms of seeding if the patient eventually goes on to a Whipple surgery, a Whipple's procedure. Conversely, if we're doing transperitoneal sampling of cholangiocarcinoma, then that tract could potentially, result in a patient becoming ineligible for liver transplantation. So we do state in this document that EUS-guided sampling of suspected cholangiocarcinoma shouldn't be performed in patients who are potential transplant candidates for that reason.
Yeah, I agree with you. It's also important to differentiate the location of the cholangiocarcinoma, right? Because if it's mostly we're talking about hilar lesions which require transplant, but if a cholangiocarcinoma is intrapancreatic, then you can still FNA it anyway because the surgery for this is not liver transplant. Correct?
Yeah, absolutely.
All right, those are excellent. So walk us through some of the other categories that we kind of divided this document into different categories of procedures. We said EUS with routine FNA and FNB. And then tell us about some of the other categories we discussed.
Yeah, absolutely. So I've alluded to a couple of them. So again, we define routine EUS as basically just, simple diagnostic EUS with or without some sort of sampling or biopsy or FNA. Then we also looked at management of pancreatic fluid collections. So both, simple pancreatic fluid collections as well as walled-off necrosis. Then EUS-guided biliary drainage as well as gallbladder drainage separately. And then celiac plexus blockade and neurolysis. And then EUS-guided variceal management, which I think has really advanced in the last decade or so. And finally, EUS-guided gastroenterostomy.
Excellent. And this dividing this document to these categories, I think is very helpful, right? We had a lot of debate on how to do it, and we decided that when you're doing a procedure, you really kind of want to know the risks of the procedure or the potential for adverse events is really based on what you're doing, right? So if you're doing EUS FNA or FNB, it's different than if you're doing a celiac plexus blockade or neurolysis. What about the issue of EUS-guided gallbladder drainage? This appears to be gaining momentum as far as advanced endoscopists are. You want to tell us about some of the maybe potential risks for this kind of procedure? What does the literature show us as far as that is concerned?
Yeah, absolutely. I mean, I think the take-home point for EUS-guided gallbladder drainage is that the evidence is still, kind of in its infancy, to be honest with you. So even, since the publication of this document, I can think of a couple of, well-designed studies that have been published that are looking at gallbladder drainage. So one key takeaway from this document is that, it will need updating without question, just because EUS-guided therapy is in such an explosive state right now. But we can say that the perforation risk with EUS, the free perforation risk, unintentional perforation, because of course all of these procedures to an extent are controlled perforations, is probably about 1.2% when we look at the best available evidence. The risk of bleeding, in contrast, is a little bit higher, somewhere between 1 and 8%. And then anytime you're putting in, a stent into the gallbladder, you have to think about issues of either, stent dysfunction, be it migration or occlusion. So again, very low sort of studies on which to base these numbers, but we can say that migration and occlusion kind of range in the 2 to 10% range overall when you're talking about gallbladder drainage.
Excellent, excellent. I know to your point, we are now doing a dedicated guideline document on EUS-guided biliary drainage. It has 5 or so PICO questions. So I would ask our viewers and readers to be on the lookout. Hopefully, this is probably, I would say, 6 months to a year from publication, so it will be a while. But we're, as you said, this is an explosive field within advanced endoscopy. And it's still early on, not a lot of RCTs, if you will, which is a common issue in GI, as you know, we've been reviewing guidelines for a long time, and we frequently find this issue that we don't have a lot of RCTs in many of the subject matters that we address in GI, but some of them we do, so we're looking for some good evidence. And I think there's some good studies about EUS-guided biliary drainage, and I think this will continue to evolve, like you said. What about the issue of celiac plexus blockage and neurolysis? I know. What are your feelings, and what did the literature show about this? I know some centers are not very excited about doing this. Other places do it. I do it every once in a while. I find it helpful in select patients. What kind of things should we be looking out for in terms of explaining to the patient the potential risks of this procedure?
Yeah, I mean, I think the sort of big 3, so to speak, that we looked at in terms of complications or adverse events that are common to all EUS-guided procedures are kind of perforation, hemorrhage, infection, right? So the good news is that, CPB and CPN, the risks of those big 3 don't seem to be very different to just routine EUS. Which is great. Now, there are some kind of rare to more common adverse events that are associated mostly with this type of procedure, and that's really due to the actual injectate, rather than the actual instrumentation. So you can see things like diarrhea, hypotension, subjective inebriation, even, or self-limited abdominal pain, ranging from anywhere from 2 to up to 30% when you're talking about diarrhea. So those are things to to keep in mind. And then there are very, very rare case reports, which any endoscopist needs to be aware of, obviously, but thankfully are extremely rare. But things like retroperitoneal abscess formation and empyema have been reported in case reports and case series. And then horrifically, things like ischemia or necrosis of vascular structures or intraperitoneal organs, which have even been reported to result in death or paraplegia. So I think things like withdrawing on your syringe, to confirm that you're not in a vessel is crucial when you perform this technique. There's no evidence to support that, but that's just kind of a common sense thing.
Definitely, you don't want to be injecting alcohol into the aorta or the celiac artery. Excellent. Any final thoughts on this, and for our colleagues who do these procedures every day? As you said, the EUS has surpassed ERCP, and we do it quite often. The indications are various, and the interventions, besides diagnostic EUS, interventions are also a lot. So any final thoughts from you about this, Nauzer?
No, again, thanks for the opportunity for this. I think, the purpose of this guideline overall is really to inform endoscopists of the best available estimates of risk. But again, like I said, we have to keep in mind that these techniques are constantly evolving, and that, there are many novel techniques that we haven't even really touched upon that are just being developed. So look forward to the next, iteration of this in a few years, undoubtedly. But in the meantime, I hope it's a useful resource for endoscopists.
I agree with you. I think anybody doing EUS should be aware of some of these adverse events and understand some potential risk factors that we try to highlight. we've made it easy for our colleagues to find this document. You can access it on our website, the GIE website and the ASGE website for free. You don't have to subscribe to GIE to access our guidelines. And I encourage everybody who does EUS or any EUS guided procedure to look at this and to try to understand some of the risk factors and see if you can mitigate some of these risk factors, and also to counsel patients. Like you said, most of the times these procedures are very, very safe. However, sometimes things don't work out as well. So having the understanding what the potential adverse events are is key, because then you can also be on the lookout for these adverse events and you can recognize them early and manage them early. Nauzer, I wanted to thank you again. I know this was a very important document that you did in a record time. So I really want to thank you for your effort and for your help in the standards of practice. I want to also give many thanks to everybody else on the standards of practice committee who helped us work on this document. Of course, the ESG editorial board, the governing board for reviewing and accepting this document. And of course, if you have any questions about any of our ASGE guidelines, please feel free to email the ASGE or email me personally. My contact information is on the publication, and we'd be happy to answer any questions. Thank you so much for tuning in and listening to our guideline discussion today, and we look forward to discussing future guidelines with you in the future. Thanks, Nauzer.
Thanks, Bashar.
All right.